Thanks for taking a few hours of your Sunday to spend with us here. My charge is to talk about a relatively common injury, the rotator cuff, in a very unique patient population, the overhead athlete. So first, a couple words about the rotator cuff. The rotator cuff is comprised of the four muscles that originate on the shoulder blade and then attach as a single cuff of tendon on the proximal humerus. The subscapularis on the front internally rotates, the infraspinatus and teres minor in the back externally rotate, and then the supraspinatus on top abducts or elevates the arm in space. But more importantly, these rotator cuff muscles work in force couples to maintain balance to the shoulder in order to create a fixed fulcrum so that the remaining muscles can power the arm in space. The subscapularis opposes the infraspinatus in the axial plane, and the supraspinatus actually opposes the deltoid to a certain extent in the frontal plane. And this balance, these force couples, will become important. When we talk about typical rotator cuff tears, they're usually multifactorial. There's a number of different causes that can contribute to these tears in an average patient. Some of them are traumatic, but by and large, most of them are due either to extrinsic impingement of the cuff by the surrounding structures, including the acromion and acromial spur, for example. But the most important cause of these typical rotator cuff tears is intrinsic degeneration over time. So these tears tend to be age-related. Their incidence goes up over the years, and they're typically chronic. So patients will complain of insidious onset of pain. The pain is worse at night, and as these tears become bigger, the patients will start to notice weakness as well. But overhead athletes are certainly unique, and it's important to first understand, who are these overhead athletes? Of course, many of them are baseball players, but so too are tennis players, volleyball players, swimmers to a certain extent, and also niche athletes such as javelin throwers are certainly included in this group. I think the archetype of the overhead athlete is certainly the baseball player, in particular the pitcher, but these overhead athletes also come in all different shapes, sizes, and ages, and I think how do we compare the top panel to the bottom panel? The bottom panel is certainly who we see most of, our community athletes in their 60s, 70s, and 80s, certainly more common in these days. And when these athletes come to us with cuff tears, we have to understand that they're probably the more typical cuff tears that we talk about, whereas when our elite athlete, the high school, collegiate, professional athlete comes to us, it is a very different type of rotator cuff tear that we see. So if we're going to understand the throwing athlete, we have to understand the throw, and our understanding of the throwing motion has undergone evolution over time. We now sort of divide the throwing motion into 6 different phases, and there's 2 critical instances during the throw when shoulder injuries are likely to occur. So first is the late cocking phase, which begins with lead foot contact and culminates in maximum external rotation. That's the first critical instant of the throw. Deceleration phase is the second critical instant of the throw, a brief phase that begins with ball release and then culminates with maximum internal rotation. And it's, again, during these 2 phases when shoulder injuries are most likely to occur. So during the late cocking phase, the shoulder can be externally rotated up to 165 degrees in these throwers, and there's a significant amount of torque placed upon the shoulder and a significant amount of shear force applied to the glenohumeral joint, more than 300 newtons. During the deceleration phase, there's a violent contraction, an eccentric contraction, as Tim pointed out, of the rotator cuff muscles and other musculature. And this is an effort of the body to dissipate the energy that's accumulated during the throwing motion. As a result, there's more than 1,000 newtons of compressive force across the shoulder joint. So we can understand why shoulder injuries are likely to occur during this phase. Throwers have undergone certain anatomic adaptations in order to cope with this relatively unnatural motion and activity. And the most common one that we talk about is range of motion difference with the average patient that we see. Throwers tend to have a significant increase in external rotation at the cost of internal rotation, and we describe this as a shift in total arc of motion. So the total arc shouldn't be different in terms of how many degrees, but it's shifted in favor of external rotation with less internal rotation. This is different than GIRD, glenohumeral internal rotation deficit. With GIRD, there's actually more of a loss of internal rotation than there is a gain in external, and this decrease in total arc of motion can leave these athletes vulnerable to injury. But these athletes don't come to us complaining of GERD or complaining of cuff tears. They typically complain to us on the field or in the office of a dead arm. And thought leaders in the care of these throwers have actually defined dead arm has any pathologic condition which affects their velocity and control due to pain or unease in the shoulder. And then it's our job as the orthopedic surgeon to try to decipher, what this dead arm might mean. So it's very helpful to us to try to organize the sometimes confusing terminology that's used in talking about these throwers. So I like to divide the terminology into terms that refer to causes and terms that refer to effects, terms that refer to risk factors and terms that refer to the true pathology. So things that can cause shoulder problems in the thrower include posterior tightness, anterior looseness, and the sick scapula. And then these things can ultimately lead to the pathology, slap tears, or the topic of my talk, cuff tears. So let's talk a little bit more about these different causes. So anterior capsular laxity. This is due in part first to fatigue of the dynamic stabilizers, which are, at the end of the day, the rotator cuff. Also, there's obviously repetitive microtrauma and attenuation to the capsule itself, and this allows the ball to slip out the front to a certain degree. In contrast with posterior capsular tightness, the ball relative to the socket tends to shift up and to the back. Now, this can be a good thing because it allows the thrower to achieve that incredible external rotation that's required, but it can also lead to pathology. And then finally, the sick scapula. It's really super important to examine the shoulder blade in each and every patient we see, but particularly the throwing athlete. And Burkhardt coined this term, sick scapula. It refers to malposition of the scapula when you look at them in a static position at rest, inferior medial prominence, pain over the coracoid, and also, importantly, dyskinesis of the shoulder blade or abnormal movement of the shoulder blade as the arm moves in space. Very important to recognize sick scapula. So ultimately, cuff tears in the throwing athlete occur by way of three distinct mechanisms, keeping all those risk factors in mind. First is internal impingement. We talked about how tightness in the back of the shoulder can shift the ball up and to the back. And again, that can be a good thing because it allows maximum external rotation. But it can also allow pathologic contact between the proximal humerus and the rim of the socket. The rotator cuff and the labrum get caught in between, and they can subsequently tear. Now, we have to understand that each and every one of us has a certain amount of internal impingement every time we get into this position. What makes it pathologic in throwers primarily is that it's excessive and it's repetitive over time, and then it leads to attritional tearing of these structures. Secondly, subacromial impingement. In these athletes, they can get, as we talked about, dynamic fatigue of the rotator cuff, and they lose those important force couples, the balance to the shoulder, so the ball can drift up to a certain degree, bringing it closer to the acromion. They can get posterior capsular tightness, as I mentioned a couple times, which can bring the ball up and back closer to the acromion. And finally, sick scapula, on the other hand, can bring the acromion closer to the cuff. All these things can lead to secondary impingement and a bursal-sided tear in the rotator cuff of a thrower. And then finally, tensile overload. I mentioned during the deceleration phase, there's a violent contraction of those rotator cuff muscles to try to dissipate the energy that's accumulated. Well, this can also, unfortunately, lead to tensile failure of the articular side of the rotator cuff that has relatively less blood flow than the remainder of the tendon. Fortunately, most of these tears can be managed without surgery. That's a good thing for these athletes. These include all the things we typically talk about with rehab and therapy, rest, NSAIDs. You then move to proprioception and neuromuscular control, a focus on range of motion, and ultimately strengthening. But I think the theme of this talk is to first take a step back and understand what were the risk factors, what were the causes of the tear in this athlete, and then address the causes with a focused therapy program. So if they have GERD, if they have an internal rotation deficit, then the therapist will work on sleeper stretches shown in this panel or horizontal adduction stretching. If sick scapula is an important cause, then you're going to focus on strengthening and re-education of the periscapular muscles. A thrower's 10, a group of exercises focused on the thrower, is incorporated. And then finally, an interval throwing program as the athlete prepares to return to the mound. Some tears will require surgery if they don't get better with rehab, and the two primary ways we treat these is either by simply debriding or cleaning up the tear, or a true repair, and there's a couple different ways to accomplish the repair. The decision about whether to simply debride or to repair is based primarily on how much of the footprint attachment is involved, and this is based on a definition of the footprint from medial to lateral of about 12 millimeters, and traditionally, if less than half of the footprint was involved, we would debride. And if more than half was involved, we would think about a repair. But this threshold has undergone somewhat of an evolution over time, and now we tend to distinguish the threshold for throwers with the threshold for non-overhead athletes, like the football player or rugby player, for example. So we try to avoid repairing a tendon in a thrower because it can overconstrain the shoulder, and it might well end their career as a competitive pitcher, for example. So more than 3/4 of the tendon should be involved in a pitcher if we're going to think about repairing that tendon. Otherwise, we typically would favor a debridement. Well, there are two primary ways to accomplish a repair. First is a transtendinous repair, where you can see we work actually through the tendon in order to place our anchors and then use sutures to tie down the tendon to bone. We leave the intact lateral footprint alone. This allows us to reestablish the footprint in an anatomic way, preserve the intact healthy tissue, and hopefully avoid that length tendon mismatch or that over-tensioning that can occur with a traditional full thickness repair. But full thickness repair is certainly still an option. Of course, it's an option if you already have a full tear. But even in a partial tear, some surgeons prefer to complete the tear, create a full thickness tear, and then repair it as you would any other full thickness tear with a wide variety of techniques that have been described, from single row to double row, transosseous equivalent, tension band, and the list goes on and on. When you look at the large number of papers that have been written, outcome studies using all these different techniques, debridement and the repairs, you see that in general the outcomes are favorable, with good to excellent results that range from 66 to as high as 98%. Unfortunately, though, return to sport is much more variable. Depending on what technique you read about and what paper you choose, return to sport can be as low as 33%. The good news is it can also be as high as 98%. So you really do have to counsel your patient and have some realistic expectations. In trying to answer the question about which is the better technique, full thickness repair or transtendinous, the question hasn't really yet been answered. But a couple recent papers suggest that maybe there's a slight advantage to that full thickness approach. But we'll see what the literature provides in the next few years. I think the most important part of defining your treatment strategy in these athletes, though, is not necessarily how you're going to address the cuff tear itself, but also, again, identifying the true causes of the pathology and addressing all those causes in your strategy. So you can see this algorithm. If you have anterior looseness as a part of their picture, then you might want to include a procedure to address that issue with a stabilizing surgery. If you have GERD, internal rotation deficit, then again, you may have to include a capsular release for that patient. And finally, if they have a concomitant rotator, a labral tear, which can be a part of that internal impingement picture, you may be thinking about a debridement or a repair of the labrum as well. So in summary, the throwing motion exerts a tremendous force on these overhead athletes' shoulders. And when they do sustain cuff tears, it's usually a result of a complex interplay of a variety of processes that we've talked about. You have to identify and treat all the relevant pathology in order to try to get these athletes back to their sport of choice at their previous level of competition. Thank you very much. Appreciate your time.